Welcome to the speakers. Welcome to all the faculties and the chairpersons for starting this episode of webinar, the third episode of this webinar series, OBGYN Pulse Midweek webinar series. To start the session, let me invite Dr. Vijaya ma'am, who is the convener, who is a friend of you all. Can we have Vijaya ma'am's CV, please? So, Vijaya ma'am, who is now a candidate for chairperson for the Foxy Medical Education Committee of 2025, is a renowned academician. She's been a president of OGSI from 2024 to 25. She's been a former director of IOG from 2019 to 22 and former director of Institute of Social Obstetrics. She's had many awards bagged with her, and she's been a member of Foxy Medical Education Committee, member of the OGSI Medical Education Committee, a person with more than 3 decades of teaching experience for UG, PG, and many of them are her students here in Chennai. And she has been a faculty for the UG and the PG revision courses, and she's been a state-level master trainer in both AMONC and in cervical cancer screening programs. She's been a national master trainer in safe delivery practices and in Dakshita, and she's also been a scientific chairperson in the conferences. She's played a very important role in Lakshya certification, and she's been an examiner, a very academic person who has run the Aksharam webinar series from April to March 2025. This is from last year, April, that is April 2024 to March 2025, following which now she's running the next academic series, which is the OBGYN Pulse Midweek webinar series. And the convener of Aksharam webinar series, the present convener of OBGYN Pulse webinar series, a person with huge teaching experience. Vijaya ma'am, let me call you to start up and convene this episode of webinar, please.
Thank you, Madhu, for a lovely introduction. Can I have the slide of Madhupriya, please? Madhupriya is the co-convener for all of my webinar series, and she is actually a fertility physician. She works in Nova IVF, and she has done her MBBS, DNB, and MRCOG, and she has diploma in Gynae Lab, Apollo and Kiel, Germany, and she has got fellowship in reproductive medicine from Preterm, and she's a clinical director and senior fertility physician, more than 15 years in Nova IVF fertility at MRC Nagar. She has got lot of awards for papers and posters, and Best Youth Icon Award in 2023, and she has got lot of publication in BJOG and IGCP, and special interest is the biological hair for poor ovarian and sperm reservation, and also she has a special interest in oncofertility, and she is the backbone behind this webinar series, and she is only calling all the chairpersons and communicating and sending the links and all. Thanks, Madhu, for excellent coordination.
Thank you for the cooperation, ma'am. Thank you so much for involving me, ma'am. Thank you very much, ma'am. We'll start the session with a prayer and the lighting of the Kuthuvedakku. So we have two good sessions today, which is going to be the first session by none other than Dr. Sharmila Ayavu, ma'am, and the second session by a great dear friend, Dr. Santosh Gupta. So moving on to the first session, can I have the next slide, please? To introduce the chairpersons and to start the session one, can I request Vijaya, ma'am, for you to introduce the chairpersons, please, ma'am?
Yeah, I welcome Dr. Manu Singla. She's an MD, OBGYN from DMCH, and she's doing a private practice at Singla Hospital for the past 20 years and life member of Foxy, IMS, SFM, and IMA. Presently, she's secretary of the Ludhiana Obstetric Gynec Society and member of the Foxy MTP committee. Her areas of interest are ultrasound and high-risk pregnancy, and she has participated as a faculty in national and state conferences, and she's a Foxy master trainer for DIRA, and she has contributed many articles and case reports in journals, magazines, and newsletter. Welcome, Manu.
Thank you, ma'am. Thank you for the kind introduction.
Thank you, Manu. Dr. Ginny Gupta, she is MBBS, MD, FIC, OG, ex-PGA Chandigarh, and she is the president of Ludhiana Obstetric Gynec Society. She is a consultant in Healthline Hospital, Ludhiana, visiting consultant at Cloud9 Hospital, Ludhiana, member of SFM, SMC Foxy, and AFAWF, Manyata champion and a coordinator Punjab. She has lots of achievement in national and state level congresses, and her field of interest is in safe motherhood, high-risk pregnancy, and adolescent gynecology. Welcome, Dr. Jeannie.
Thank you, ma'am. Thank you.
And Dr. Parneet Kaur. She's a professor and head of the Department of OBGYN, GMC Patiala, and she has 23 years of teaching experience and examiner for UG and PG for the last 14 years, 70 publications in national and international journals, and contributed 3 chapters in books, and reviewer of 3 reputed specialty journal, and president of NABA Obstetric Gynec Society, and she has special interest in high-risk pregnancy, emergency obstetrics and contraception, master trainer for PPIUCD, member of Foxy, ICOG, IMS, IAGE, PCOS Society, and NARCHI and SFM, and CELSI and IMA. Welcome, Dr. Parneet Kaur. Dr. Parneet, you're there, I think. Yeah. Can I introduce Dr. Nishi Karg? She's MD, FACOG, MNAMS, FAC, MCH, FAAOG, Director Karg Multi-Speciality Hospital, Faridkot. She's an ex-professor, PIMS Udaipur, more than 34 years of experience in OG, and she's the president of Cave Fox Society, member of the MTP Committee of Foxy, member of IFUMB, and member IMA, member ISOBOB, and many credit points in MICOG, and member MTP Committee Foxy, conducted workshop in IUI in GCS Medical College. And
It's okay, ma'am. Thank you very much.
It's okay. It's okay. We have to know you. Everybody has to know you. That's it. Actively creating awareness and cancer prevention in rural areas and peer reviewal, an active member of the Inner Wheel and various social organizations. Welcome, Dr. Nishi.
Thank you. Thank you.
Good evening. Should I start the?
Yeah, please introduce Dr. Sharmila.
It's my great good evening, everybody, to the August faculty. It's a great privilege to be able to introduce the brilliant academician from Southern India, that is Dr. Sharmila Ayavu. I would like to tell you at the outset that when we attend the Foxy conferences, we choose the sessions in which Madam is a speaker and we attend them, and it is a great privilege. She is our senior, and among her many accolades, she has been Vice President of Foxy 2024, Trichy OBG Society. She's a President, Chairperson of the Clinical Research Committee of Foxy, and ICOG Governing Council member. In fact, I received my fellowship of ICOG under her, National Coordinator for so many programs, and WHO Southeast Asia Region MDSR India member, President of the Menstrual Hygiene Management Consortium, and Secretary of Justosis India Association and academic wing of Assisted Reproduction Technology, Trichy. She is also the managing council member of the PCOS Society of India. Apart from all these accolades, I would just like to tell that Dr. Sharmila is a brilliant orator. And some of her slides, which I have kept, have always been used by me for learning again and again. And let us all just enjoy the flow of her lecture now. Welcome, Dr. Sharmila.
Thank you,
I would
Ginny.
just like to add a few things. Shamila is a very, very good friend of mine and very easy to communicate. That is very, very important
Yes.
in human relationship. Unless and until they talk to us freely, we will be really hesitate to convey our ideas and discussion. And I wanted her to talk on gestational hypertension, but then Ashish said I will only talk. So the first session was by Ashish sir. Then I told Sharmila talk about preterm. It will be really good. Everybody wanted to know the current updates, and Ambit's a busy schedule. She is going for all the revision courses and everything all over India, and only for me she's great. Thank you, Charmila. Thank you so
Yeah.
much.
Yeah. Thank you, Dr.
When
Vijaya.
we need the Foxy leaders to be good academicians, so that is why we will always look up to you. So never leave the academy and the leadership.
Thank you so much. Very, very, very kind of you, Ginny. And I'm meeting you, I think, after a webinar which we had on liver disorders, right?
So in Kolkata, we attended all your sessions, me and
Sessions,
Dr. Vidhu. हमने सारे attend किए.
Thank you so much. It was wonderful
And
meeting
I
all of
should
you.
also say, when Charmila is talking, all PGs wanted to attend. So I sent the link to everyone. They are choosing the speakers, as you said, Ginny. They are just seeing who's speaking.
Who's
Yeah,
the speaker?
yeah, she has such a great impact on the students. Thank you,
Thank you. Thank you, Dr. Vijaya. Thank you so much. It's an honor to have chairpersons, Dr. Ginny, Dr. Manu, Dr. Niba, and Dr. Parneet Kaur. Thank you so much. We have met over webinars, as well as Dr. Nishi. Thank you so much for your for chairing the session. Let me start my talk on preterm labor, which Dr. Vijaya and Dr. Madhu has asked me to do on. And management of preterm labor. When you have a patient like this person coming, like she's a primey, she's 32 years old, is now at 34 weeks of pregnancy. She's complaining of severe abdominal pain. And when you examine, she has regular uterine contractions. So how are you going to establish the diagnosis of preterm labor? And if you're establishing, how are you going to manage this patient? At 32 to 23 to 34 weeks of pregnancy, when it's in the preterm age, the diagnosis may be variable, but when you have one of these features, remember it can be preterm labor. That is, a patient will have persistent contractions, which is associated with both pelvic pressure or backache. And she can have regular uterine contractions on external tochometry. And when you see an increased vaginal discharge, or can be leakage of fluid in the form of vaginal spotting or bleeding, think it may be preterm labor. And then you have to ascertain the cause for this pain with the changes which is happening. And you have to also evaluate the fetal well-being, because that will help you to decide whether you're going to deliver her at once or you're going to wait for some time. And these two conditions have always should be excluded before you want to continue the pregnancy, because both are very dangerous conditions for the mother and the baby. To rule out chorioamnionitis, with an abdominal exam and a fundal assessment, you will find out whether there are tenderness in the uterine wall. And consider a complete blood count, which should include a differential count. And suppose your examination findings are equivocal, you can consider an amniocentesis. And to rule out an abruption, of abdominal examination with the fundal assessment is important. But complete blood count may not help much for to rule out anything else except for the coagulation factors, which can have a problem there, or she can have anemia. And a coagulation panel is a must when you suspect abruption. And other than that, you will have to rule out a urinary tract infection as a reason for the pain which is the pain which is happening with the mother. And for that, you will need a urine analysis along with a urine culture. And when you want to check for whether she's gone into labor, a sterile speculum examination is the one you should do first. It's not a PV examination. And when you do a speculum examination and you have a facility for doing a fibronectin level, you can do a fetal fibronectin testing by taking a swab before you do a digital examination. Because if you do a PV, the swab reports will not be correct. And you can do a group B streptococcus culture. You can consider a wet prep evaluation for yeast, bacterial vaginosis, or trichomonas as a reason for the vaginal discharge. Then consider gonorrhea and chlamydia swabs. And suppose you want to know whether the membranes are ruptured, you can check for the rupture of membranes by seeing the pool of fluid in the vaginal cavity, vaginal space. And you can consider doing a nitrogen test, a pool test, Fern test, or placental alpha microglobulin 1 protein, but none are not available as in a clinical setting. And you should do a digital examination only when there's no evidence of a leaking in a preterm pregnancy and there's no placenta previa, which should be ruled out by an ultrasound before you do a vaginal examination. And you can do a continuous external fetal monitoring to evaluate the fetal well-being, and a tokometry can also be added there. And that should be done only when there's a viability to the pregnancy. You cannot do it for a pre-viable pregnancy. And consider doing an ultrasound for fetal size, fetal presentation, the maximum vertical pocket for a amniotic fluid assessment, as well as for a placental location. And then you should do a, suppose you're finding these findings, one second. You can confirm you can confirm suspected preterm labor, and that should be confirmed only when there's a cervical change in the form of cervical dilatation of 3 centimeters or greater, along with a 80% cervical effacement, and they should have the symptoms of acute preterm labor. Suppose the patient is not having abdominal pain and you're checking the cervix and there are some changes, to assume it's preterm labor. She can be just in quiescent phase. There may not be labor at all. It should be a combination of all three before you diagnose it as preterm labor. And suppose there's an equivocal evaluation, you don't know whether she's definitely into preterm labor, and that will happen when the cervical dilatation is less than 3 centimeters and the effacement is less than 80%, but the patient is still complaining of pain, with many of our patients do. And then you need to do an additional evaluation to confirm or rule out preterm labor. And for that, you can use a transvaginal ultrasound, you can use a fetal fibronectin which is available, or if these facilities are not available and it's in a low resource setting, you can repeat a clinical examination after some time, or you can combine all of those and then identify whether she is definitely into preterm labor. Regarding transvaginal ultrasound for the diagnosis of preterm labor, suppose you see a short cervical length of 20 mm, and according to NICE guidelines, 15 mm is considered as short cervix. It is considered as confirmed preterm labor. So she's just having occasional pain and she's not having much of cervical changes, but transvaginal ultrasound says that the cervix is short, then it should be considered as a preterm labor. But suppose the cervical length is equivocal and that's between 20 to 29 mm, then probably a fetal fibronectin, which is available, if it's available, can be used to add on to the diagnosis. And according to all these guidelines, SMFM, ACOG, and NICE, suppose the fetal fibronectin testing is positive, that is, you see a concentration more than 50 nanogram per ml, it is diagnostic of preterm labor. But they say you need not use a fetal fibronectin testing if you have a vaginal ultrasound, because that will identify the shortening of the cervix before the patient goes into full preterm labor. And there's no need to use both ultrasound and fetal fibronectin. And doing a fetal fibronectin by itself has not shown to decrease the incidence of preterm labor or affect the neonatal outcomes in women with symptoms of preterm labor. And what about the patient? What about the setting where you don't have an ultrasound and you don't have a facility for fetal fibronectin? Then the alternative strategy will be to continue to monitor the mother for the next 1 to 2 hours and repeat the manual cervical examination. And if if the cervical change has happened and it's more now she should be admitted and treated for preterm labor. But remember, the clinical judgment is the best method of identifying whether the patient is in preterm labor and to determine the best plan of care for each woman. You have to individualize the management. And how do you treat? You will admit if there's a confirmed preterm labor, and suppose she's in a smaller facility which does not have an NICU care, she should be shifted to a higher level with the NICU facilities available. Give her corticosteroids while you're shifting for fetal maturity, and initiate antibiotics for GBS prophylaxis when appropriate. What about tocolysis in a patient who's developed preterm labor? We know that the contractions are the commonly recognized antecedent of preterm birth, and that's why if you stop the uterine contractions, probably that will be the best method of stopping the preterm labor as a therapeutic intervention. But the indications of tocolysis is you can give it only for 48 hours maximum, only if there's no contraindication. And it may help in a short-term prolongation of maintaining the pregnancy, while you can give the steroids and magnesium sulfate for baby's lung maturity and neuroprotection. And suppose there's a preterm leaking membranes and there is no maternal infection, then probably you can give an tocolytic while you're shifting the mother to a higher center. And also, even in a PPROM, if you've ruled out a maternal infection, you can give steroids to help the baby's lung maturity. Otherwise, tocolysis should not be continued for a prolonged period of time. Contraindication for tocolysis in established preterm labor is when there's a non-viable fetus, an IUFD is there, there's a lethal fetal anomaly, there's a non-reassuring fetal status, there's associated severe preeclampsia, there's maternal bleeding with hemodynamic instability. Suppose there's infection in the form of chorioamnionitis, and there are maternal contraindications to tocolysis, which is agent specific. You cannot give a tocolytic agent. And the agents which are being propagated at this point of time are the calcium channel blockers as nifedipine, the oxytocin receptor antagonist atosiban, beta-mimetics terbutaline, non-steroidal anti-inflammatory drugs, the NSAIDs, and that is indomethacin and magnesium sulfate. The choice of drug according to the NICE guidelines is consider nifedipine between 24 and 36, but give her definitely nifedipine between 26 to 34 weeks of pregnancy. And this is a new recommendation. In 2015 of November, it was an off-label use for nifedipine. And suppose you have a contraindication for nifedipine, according to NICE guidelines, you should consider atosiban, oxytocin receptor antagonist, and they say you should not give beta-mimetics for tocolysis. And this is the American College guidelines. For them, the first drug is calcium channel blockers, and next is indomethacin, and third is the beta-adrenergic receptor agonist. Nifedipine should be given at the initial dose of 20 milligram, and every half an hour you can give a further dose of 20 milligram if the contractions continue. And once she has stopped her contractions, the maintenance dose is 20 to 40 milligram orally, 4th-hourly for 48 hours, but do not exceed 160 milligram in 24 hours. And because any dose which is more than 60 milligram will have a 3 to 4-fold increase in serious side effects like hypotension, and that's why it should be used with extreme caution. Atosiban is an intravenous injection, can be given slowly over 1 minute. A continuous infusion can be set up for the next 3 hours, and then for the next 45 hours, you can give the infusion at 8 ml per hour. But the total duration of treatment here also should not exceed more than 48 hours. And you can consider, as far as atosiban is concerned, that you can give further 3 retreatments if she again develops episodes of preterm labor. But for the other tocolytics, there's no indication for reusing them again and again. When you compare nifedipine and atosiban, the Episode-3 trial, which was a multicentric randomized control trial, and it compared tocolysis with nifedipine and atosiban in 503 women with threatened preterm birth, and the neonatal outcome did not differ between both treatment arms except for a higher rate of intubation of the baby in the atosiban group. And regarding intravenous magnesium sulfate, it is not a tocolytic. It is actually a neuroprotective agent in the setting of preterm labor. That's why when you want to consider tocolysis, remember you can give another agent as a tocolytic agent along with magnesium sulfate. But there are concerns regarding the combination of beta-adrenergic receptor agonist and calcium channel blockers. That is, you cannot combine terbutaline with nifedipine, but you can. That is, you cannot give nifedipine or terbutaline along with magnesium sulfate. But now there are many studies which have said that you will give magnesium sulfate along with nifedipine, there are not much of problems. But there is a serious thought about beta-adrenergic receptor agonists because of their potential effects on the cardiovascular system. And before 32 weeks, indomethacin is a good drug for use in conjunction with magnesium sulfate because that will not have the side effects of either beta-adrenergic receptor agonist or calcium channel blockers when combining with magnesium sulfate. Indomethacin dose is 50 milligram loading dose and the maintenance dose is 25 milligram every 6 hours. But remember, it can cause necrotizing enterocolitis and premature closure of the ductus. And there are not much of studies regarding the duration of therapy and the gestational age at exposure and the interval between exposure and delivery because the potential risk of PDA which can happen when you give indomethacin. And that's why you have to weigh the potential benefits and risk when you're comparing with other tocolytic agents and when you're giving indomethacin. Regarding terbutaline, the FDA issued a warning because of reports of serious maternal side effects with its use, and it also reported some deleterious behavioral effects in the offspring after an in utero exposure. And that's why it can be used for a very, very short-term inpatient use, as in a mother who has developed uterine hyperstimulation with some form of induction of labor. And that there you can use it as an acute tocolytic, and it's very useful. But it should be used only in monitored setting and can never be given beyond 48 to 72 hours. Oral terbutaline has been warned against usage by the FDA because it does not have any efficacy in preterm labor prevention, and there's also a potential maternal risk, and that's why FDA has said that oral terbutaline should not be used to treat preterm labor at all, but you can consider IV terbutaline only for a short-term use for stopping a hyperstimulating uterus. Regarding the nitric oxide donors, the GTN patches that can be used as And patches can be applied to the skin of the abdomen. And after 1 hour, if there's no reduction in contraction frequency or intensity, an additional patch is applied. And maximum 2 patches can be administered simultaneously, can be left in place for 24 hours, after which they're removed and the patient reassessed. But it's not much use because of the significant maternal side effects which can happen with GTN patches. And regarding the maintenance therapy with tocolytics is totally ineffective, except atosiban, which can be used as a maintenance therapy if the patient is developing contractions again and again, but that also cannot be used for more than 3 episodes. So does tocolytic therapy actually improve the outcomes? They actually may provide a short-term prolongation of pregnancy, and that can help you to administer steroids and magnesium sulfate, as well as transport the mother to a tertiary facility. But there is no direct favorable effect on neonatal outcome or any prolongation of pregnancy, even if you give tocolytic. So that actually does not translate to any neonatal benefit just because you give tocolysis to prolong the pregnancy. And what about multiple pregnancy? Can you give tocolysis in patients who have got twin pregnancies along with preterm labor? It is associated with the great risk of maternal complications, which includes the dangerous pulmonary edema. And it's known to reduce the risk of preterm birth or improve neonatal outcomes in multiple gestations. And there's also no data to support the use of steroids and magnesium sulfate. But because you definitely know that you have a benefit with all these drugs in singleton pregnancies, preterm labor, experts recommend the use for preterm multiple gestations also, but even though studies are not available separately for multiple gestations. And what about the prophylaxis in preterm labor? How can you actually prevent preterm labor? There are so many risk factors for developing preterm labor: the ethnicity, the age of the mother, lifestyle, environmental factors. Suppose there's no health care during pregnancy, mothers who smoke, drink alcohol, or use illegal drugs, or mothers who are subjected to domestic violence, which can be physical, sexual, or emotional abuse, multifetal pregnancy, maternal infections, bleeding, hydramnios, uterine fundal abnormality, cervical insufficiency, fetal anomalies, autoimmune disease of the mother, and gestational hypertension. All that are risk factors for preterm labor. And there are certain history which will tell you that the mother is going to be predisposed to a preterm birth, and that can be a previous preterm birth which has had, a previous late miscarriage. Suppose she has undergone a surgery on the cervix in the form of an excision. Suppose she has had a short cervix in this pregnancy, and then probably a cervical ultrasound with a fetal fibronectin enmeshment can be used to predict whether this mother will go for a preterm birth in this pregnancy. And what about progesterones for the usage to prevent preterm birth? Williams Obstetrics has said that it is one of the most debated topics, whether you can use progesterones for preventing preterm birth in a mother who has suffered a prior preterm birth. And the drugs which have been tried are 17-hydroxyprogesterone caprate between 16 to 36 weeks, vaginal progesterone gel, or the oral progesterone. But there are no studies to confirm that these drugs are definitely useful for the prevention of preterm birth. And now they've actually withdrawn 17-hydroxyprogesterone caprate in the management of prevention of preterm birth, because they say we sympathize with women who are at risk for recurrent preterm birth. That could actually result in fetal death or significant lifelong health benefits in the neonates. But retaining on the market a drug not shown to be effective for this use does not protect or promote their health. That is the statement by the FDA. But when you go through the studies which made them withdraw the drug, it will tell you that this drug did not actually harm the mother or the baby. It was actually found not to be of use in the white population compared to the black population. It was found to be of use in the black population, but because the second trial, which was conducted in the white group, did not show benefit, they withdrew the drug. So, but in India, we still use this drug for prevention of preterm birth, and it seems to be useful. And the short cervix, as said previously, none of these agents have been found to be of useful. And 17-hydroxyprogesterone caprate cannot work for a short cervix. It can help for a prevention, but it cannot stop the cervical ripening. And so what are the prophylactic strategies as far as the different guidelines are concerned? All of them talk about only vaginal progesterone as an intervention for preventing preterm birth in a person who has suffered preterm birth in a previous pregnancy, and now she's having a singleton pregnancy. For this patient, according to the RCOG, you will do a cervical length screening before 16 to 24 weeks, and you can give vaginal progesterone. And suppose with your screening, you find that the cervix is becoming short, you can continue the vaginal progesterone, and if it's becoming very short, less than 15 mm, you should go for a cerclage. That is RCOG. According to the Society of Maternal Fetal Medicine, start screening from 16 weeks, do it every 15 days till 24 weeks of pregnancy, give 17-hydroxyprogesterone caprate, but that was a previous recommendation. Now they've also changed. and give vaginal progesterone if there's a short cervix, which is less than 25 mm. And you can also consider a cerclage when the cervix is shortening below 25 mm. According to FIGO guidelines, you will do the screening at 19 to 20 weeks, give vaginal progesterone for both prevention of prior preterm birth or for a preterm birth or for a short cervix. These are the guidelines for prophylactic strategies for prior preterm birth. And what about multiple pregnancy? Remember, the pathogenesis of preterm labor in multiple pregnancy is totally different from a singleton. In multiple pregnancy, it is because of an increased uterine distension. And there's an endocrine environment which is different from a singleton pregnancy. There is more estrogen, more progesterone and sex steroids compared to a singleton pregnancy. In singleton pregnancy, it is actually the functional withdrawal of progesterone which causes a preterm birth. And progesterones will prevent apoptosis in fetal membranes under both basal and pro-inflammatory conditions. So even if there's an infective or an inflammatory pathology, the progesterones can prevent the apoptosis in the membranes and prevent a preterm birth. But that is totally different from a multiple pregnancy. So what about a preventive strategy in multiple pregnancy to prevent preterm birth? IM progesterone. Can you give vaginal progesterone or cervical cerclage? The up-to-date 2018 was clear. They said no treatment is reasonable because none of that can actually help in prevention of preterm birth in a multiple pregnancy. But there was a big study, a randomized trial where they compared almost like a meta-analysis where 6 trials were analyzed, and they said vaginal progesterones will reduce preterm birth in even a twin pregnancy with a short cervix, but IM progesterones will not help in a twin pregnancy. And there was one study in 2017 which said when you give vaginal progesterones for twin pregnancy with cervical length less than 25 mm, and when you compare it with the no treatment or placebo, they said the neonatal death, RDS, and birth weight reduced significantly by almost 30 to 50% in this trial when they used vaginal progesterones in twin pregnancies. So should preterm contractions? One second. So what are the other managements you can actually do? But the evidence does not support the use of any prophylactic tocolytic therapy. And the home uterine activity monitoring, suppose the patient is coming with some form of pain and you want to monitor her, there's no evidence to say that it will help actually. And cerclage may not help in all your patients who's got a preterm labor pain, except for the pregnancy is probably at a lesser gestational age. And narcotics to prevent preterm delivery in women with contractions, but no cervical change, because these are the groups which will actually trouble us all the time, because she will be complaining of contractions, but we'll not know what to do because she's not having much of cervical changes. But you have to give some relief for the pain. You don't know whether she's abrupting inside, but you don't have any management. The best thing is always to just admit her and observe her to see how she is trending and how the changes are happening. And if the patient has gone into labor, during the intrapartum period, you can give antibiotics. Do not give when the patient is in latent phase or active phase, because antibiotics can be useful only for leaking membranes or ruptured membranes, but not for preterm labor, because that is not the pathology in most of the patients for reason of developing labor pains. But in the intrapartum period, please give antibiotics. And what about the non-pharmacological management is advised by so many centers? Bed rest is not useful. Hydration is not effective for the prevention of preterm birth, and do not routinely recommend them, because when you give them bed rest, they will, if they're not moving about, there's a potential harm in the form of a venous thromboembolism, a bone demineralization, deconditioning of the psychological effect in the mother, and those are all negative effects, can cause more problems. And if she loses her work just because she's at home to prevent a preterm labor, that is going to cause enormous problems to her and the family, and that should never be underestimated. So I'd like to conclude by saying that diagnosis of preterm labor is made if there are uterine contractions with cervical changes, and the changes should be effacement of more than 80% or more than 3 centimeters dilated cervix. And the first line therapy, which should be tocolytic, should be given only for the administration of antenatal steroids or magnesium sulfate. Maintenance therapy with your tocolytics is quite ineffective, and do not give antibiotics when there are intact membranes. And you can consider vaginal oral progesterones for the prevention of preterm birth. These are my references. I'd like to thank Dr. Vijaya and Dr. Madhu. I'd like to wish Vijaya all the best for her elections. And she's a great academician, and she's helped so many people to get through in academics, and that we know so much. And she'll be of great credit to the medical education committee. And I'd like to wish Vijaya and request all of you to help her for her elections also. Thank you so much for a patient hearing.
Thank you, Shamla, for the lovely wish. Yeah. Chairperson, I just want you to make some points on this.
It was really great to listen to Dr. Charmila, and the message she has given is really great. In initial days, we used to use duodenone and ritrodrine. I think that is wiped off of our this system.
Nishi, actually, we cannot say that it cannot be used. If you're comfortable with using your duodenone and your ritodrine, all that, use it, but don't use it beyond 48 hours, because all that confidential inquiry which was done in UK only brought out this picture that when they gave tocolytics for a long period of time, and that made the mothers land up with pulmonary edema and cardiovascular complications, and it was a reason for some others even developing myocardial ischemia. So that was a reason it was withdrawn. But consider giving her 48 hours, because you have to give her some relief, but we need not go overboard. Like before and all, we used to give IV, stop her contractions, and then put her on oral drug for a long period of time. That is not acceptable.
The nifedipine has really taken over. And
Yeah.
yes, it is going.
But nifedipine is not as useful as duodenone.
Yeah. So thank you very much for a wonderful talk.
Thank you.
Dr. Jeannie?
Yes, Sharmila ma'am, I wanted to ask you that the Drug Controller General of India, they recommend isoxazoline. Are they supporting the use of nifedipine as a first line?
I don't know, because we don't get
Yeah,
those
nice
guidelines.
nice guidelines were excellent. And I've read them.
If it depends, but we are not aware of. Actually, in Tamil Nadu and all, they're saying just don't allow anybody to cross the pregnancy at all. If she's preterm, just deliver her, because the complications are more in the mother, trying to prolong a preterm labor, because we see many times abruptions, we miss small abruptions, and suddenly it becomes quite severe. So nifedipine, I'm not finding of use. Atosiban I've tried. Is a true preterm labor can never be stopped with any of these tocolytics.
Azoxaprine is not totally out, because the ethically, legally in North, they are saying that the drug controller is recommending only azoxaprine as the first line. They have not, like Indian authorities, do not even endorse on paper Magself. We are giving it is because for neuroprotection because of the international guidelines.
What is the dose of isoxaprine they advise actually?
We are using one ampule in DNS. We were using it right and left in our
when we are PGs, I was using. Now I'm scared now.
Especially after
Yes, madam. Good evening, madam. Yes,
thank you.
One point. Up to how many weeks you want to postpone?
Madam,
India, you want to go up to
37, definitely 37. But
37
suppose it's very early preterm, at least 34 if we can achieve, it's good for the baby. At least 34.
And isoxazoline is not totally it is abundant for so many places, and it is fast to be given in high dose, 60 drops per minute. Then when it is stabilized, you give a maintenance dose. Tachycardia, hyperglycemia, all these things were there.
Hypotension.
But nowadays, what is the role of, you have not told about the progesterone injection? What the role?
That's what for
Yes,
prevention. For prevention, you can try, but not for established preterm labor. For that, progesterone is useless. It can't
because
help. Already labor is started.
It was considered by ICMR for a long time.
Madam, for prevention,
for
prevention definitely you can use. It's not stopped in India yet. You can use progesterone, hydroxyprogesterone, caprolate for prevention. But for a patient who's developed preterm labor, progesterone will not.
Right.
Ma'am, what is the dose of progesterone, vaginal progesterone for prevention?
Prevention, they're talking about 200 milligrams once daily. Vaginal.
Once daily. For how long? For how long?
Till at least 34 weeks, when you want her to at least achieve that maturity.
And oral bhi
Oral,
batao.
when you give oral also I'm finding better than actually other methods, but oral I'm always skeptical, because I don't know how much it will reach uterine surface, and quite beyond 20 weeks I don't know how much it will help. So
oral, I think we have to give double the dose.
I'm still sticking to IM progesterone caprolate. I'm still sticking on to IM progesterone caprolate. I have not
And vaginal progesterone, better. Cervical length is little doubt.
Cervical length screening should be done only up to 20 to 24 weeks. After that, she's anyway the viability starts, so there's no point in continuing this.
Thank you, Dr. Sharmila. Please comment. I want you to comment on two things. One thing is what dose of magnesium sulfate for neuroprotection you recommend?
It is the same as a Zuspan synergy. You give 4 grams IV,
Oh,
then 1 gram which should go IV hourly. That much.
Per
Yeah.
And another thing is, ma'am, what is your talk on what these RCOG guidelines come up in July 22, single steroids for a planned cesarean between 37 and 38 weeks. Do you recommend it?
Madam, if I talk from my heart, I will give steroids up to 38 weeks because I'm scared of that RDS and the mothers, like they panic if the baby is sent to the NICU and all that. So I don't know what's the harm I'm doing, but I'm having definitely lesser RDS compared to not giving a steroid. And the pediatricians actually insist on us giving the steroid. And if we don't give beyond 34 weeks and the baby lands up with a RDS, then they usually ask us, so that it's given. I know it's not recommended beyond 34 weeks, but I'm still giving. Ginny wants to say something.
Yeah, the steroid is a very big question in India because it was being used left and right in the ART pregnancy. Zara sa pain abdomen hai, steroid lagate jao.
But the
Now repeated doses are banned.
No repeated doses. Definitely
No repeated doses, and 34 is the cutoff. Because
no
ICMR has a guideline of GDM, so they have globally given the guidelines of steroids 34 ke baad nahi dena.
Should not give.
So,
no, that is all. That is all. We give it under the table. I'm telling in a webinar.
Yeah.
But beyond 34,
They tell that
it is given when the patient is actually not in preterm labor. Just a
you
patient
should
comes
not
for
give.
preterm
No
given.
prophylaxis.
the pediatrician, they tell that even in elective CS, when you do elective, they are
Yes,
not in labor, give a dose of steroids so that TNN incidence will be less.
Yes, ma'am.
To 38 week, I've been up to 39, they have written. I have given a thesis and research paper with my student for steroids. And only thing is that steroid, when you give repeat dose, only one thing is that within 7 days, another repetition can be done if you have given early and she has not delivered. Otherwise, in a elective CS, if she is not in labor, you can give. Two thoughts of that, but recent paper has come. There is no beneficial effect they have seen after 34 weeks.
We are scared not to give, that's all. Otherwise, it's not actually needed according to the recommendation.
Pediatrician lobby is very big. They have brought out studies where there are some, delays, and they are telling that you are causing harm actually.
Actually,
They need methodology.
some rare endocrine tumors they've identified in those babies which were given steroids without
Repeated
an
doses.
indication, but particularly repeated doses. Actually, Liggins Institute, New Zealand was the one which brought out the first study on steroids for preventing the RDS. And that was brought in the, I think, 80s. And then they followed that total cohort for almost 40-50 years to find out like what are the changes which has happened. And they're identifying more of asthma, more of respiratory infections, as well as rare endocrine tumors. And that's why that recommendation came. Don't use unnecessarily steroids when there's no indication, like a prophylaxis just because you feel that she may go for a preterm labor. They said that is not an indication. But what I would say is, if you had not given steroids for that cohort, none of them would have survived, or less would have survived. So at least they survived to have a problem later on. They would not have survived also, or probably they would have had so more handicaps if they had been delivered with preterm this thing. So the logic works both ways. So just for 1 or 2 cases which have developed a tumor, why do you want to stop a good drug which can actually help the baby? That is the logic. Because now we have reduced the surfactant use, all that, giving steroids enough. Surfactant usage has come down drastically now because we use steroids quite often. So that logic also should be taken into consideration, I feel, because just because all these cohort, those groups survived, and then you're identifying. They're not survived, then.
Dr. Manu, would you like to add something?
Yes, ma'am. Thank you, Charmila ma'am. You covered everything in such a short duration. One thing I will like to add, that our goal should not be only just prolongation of pregnancy. It should be, in fact, improvement of neonatal outcome. Like you said, a role of magnesium sulfate, recent studies say that it prevents CP in babies.
Yes.
So it should be encouraged.
And
Because
recently we had a problem in our place here. That is, they had done a cesarean for a preterm mother who had a multiple pregnancy, extreme preterm, and they had missed on chorioamnionitis. And for within 48 hours, she developed severe infection, went for septic encephalopathy, and passed away also. So extreme preterm, keep like the baby is important. It's an IVF pregnancy. That's okay. But
Yes,
you have to think about the mother also.
yes.
Extreme preterm, you know the viability may not be there. Why do you want to subject her? Because you're not ruled out chorioamnionitis. Chorioamnionitis is the one which will make the infection set in so quickly and can actually damage the uterus as well as the adnexa very, very quickly. So always
Our first
think twice.
focus should be
And the mother.
identifying the patients.
Should do a WBC
Regarding-
count. Now you've got CRP levels. Do something. Just rule
Yes.
out chorioamnionitis before you continue the pregnancy or take her for a section for an extreme preterm. I'm saying, like the viability is also a question.
Only one point is once we have given magnesium sulfate, she has to be delivered. No, at that point only if you
No,
give
suppose her pains go off and she's quite fine, you need not repeat the magnesium sulfate because it's actually supposed to work only when the baby is delivering, right? And not when the preterm labor process started. When the baby is delivering, we don't want that neurological damage of the because the baby is moving. So that only that much it will help. So there's no point in repeating the magnesium sulfate again and again. That can now cause demineralization also. So it's not should not be repeated again and again, but you have to judge correctly. Suppose she's gone into 3 to 4 centimeters dilatation, you know she's going to deliver, then give magnesium sulfate.
Thank you, Sharmila. Thank you. Such a wonderful talk and good take-home points. And I really thank you for amidst your busy schedule. We just
Yeah, the ICOG certificate course is going on. We just finished that.
Thank you. Thank you so much.
Thank you so much.
Thank you so much, ma'am.
Thank you.
you.
Thank you. Thank you.
Madhu, shall we move on to the next session? Yeah. Dr. Madhu, are you there? Okay. Now we will go to the second session. This is a much interesting session on IVF, achieving the best in poor responders. And I would like to introduce the chairpersons first, Dr. Madhu. Can I have Dr. Madhu's CV? Yeah, Dr. Madhu is, she's done her MBBS from GOM Co Patiala and MD Gynec from SGTP Amritsar. And she's having her own hospital, Madhu Nursing Home and IVF Center for the last 11 years. Welcome, Madhu. Are you there?
Thank you, ma'am. Yeah, I am here.
Yeah, thank you. Next, please. Dr. Komal Singh. She's done her MBBS from Ranchi, MS from Patna, and she's the HOD, Tata Main Hospital, Jamadoba, and she's the present president of Dhanbad, Jharkhand, joint secretary of the Dhanbad, Jharkhand 21-23. She has got publications in PubMed and various presentations in conferences and seminars. And she has got Upadhyay Medal and Chandravati Devi Award for the best short paper presentation at the annual conference of Box Patna. First prize in free paper category in DSOG 2019. Best speaker award at the Clinical Society meeting at Tata Main Hospital, and organized many community health programs like cancer screening, contraception, menstrual hygiene, adolescent health and antenatal care. And her areas of interest are high-risk pregnancy, preventive oncology and infertility. Welcome, Dr. Komal.
Thank you, ma'am, for the introduction and inviting me.
Thank you. Can I have the next slide, please? Yes, sir. I don't know whether he has joined Dr. Binod. He was in the annual conference and he's a physician from Narayana Multi-Speciality Hospital, and he has Sparsh IVF Center and 29 years of experience, and he has contributed so many in handling the numerous complex medical cases, and he is known for his accurate diagnosis and treating patients empathically, and specialty interests are IVF, HC, and laparoscopic and hysteroscopic surgery. He is an active member of European Society of Cardiology and Indian Society of Cardiology, and he is credited delivering the first IVF baby in this region, where all steps of IVF are done in Jamshedpur itself. He is credited with helping the elderly couple to have a child through IVF in Jamshedpur, Jharkhand. When I called him, he said he will come for the second session only because he's practicing only IVF. Welcome, sir. I hope you'll join soon. Yeah, can I have the speakers? Dr. Santosh. Yeah, ma'am. Ma'am is the heroine for the second session. Madam is Dr. Santosh Gupta, Clinical Director and Senior Consultant Reproductive Medicine at Nova IVF. She's a Joint Secretary of KIZAR, MS OBG from SMS Medical College, Jaipur, and Reproductive Medicine Fellowship from RGUHS, Bangalore. Consultant Reproductive Medicine for the past 5 years at various IVF center and simultaneously teaching and training postdoctoral fellows and thesis guide to DNB postgraduate. Got Asha Award in 2013 ISAR for oral presentation on rescue IVM. Second prize in International Conference Cutting Edge 2011 Bangalore for IVM of human oocyte. Invited faculty for all national conferences of ISAR, ACE and AACOG, and executive committee member of BSOG and ex-treasurer of Karnataka Society of Assisted Reproduction. Madam, we would love to have you and listen to you. Over to you, Dr. Santosh Gupta, ma'am.
Thank you very much, Vijaya ma'am. Thank you very much, Madhu, for inviting me. And I'm not the heroine, as madam said. But I'll try to cover up the things. It's a broad topic. Can I share my screen?
Madhu, you have come back. Unmute.
Yes, ma'am. Yes, ma'am.
You want to tell something about Santosh, ma'am?
Yeah, ma'am. Obviously, a very good friend of mine. She says that she's not the heroine. We know that she's one of the star heroines at Nova. She's been there with Nova for quite some time, for a decade now, and she has been doing extremely well in Bangalore. And she's somebody who sticks on to that ethics and, you know, the transparency which Nova stands for. And she's always been doing great work. And the patients just love to see her. They usually follow her up. From here also, patients go to Bangalore and they settle down and they usually go and meet madam. And they're all very, very happy. So she's a great person as such. Welcome you, Santosh ma'am.
Thank you very much, Dr. Madhu. I'm humbled with so much of praise. But let's begin with our topic. The topic you have given to me is a very broad topic. So in the given time, let me see if I can do justice with that. And can you see my screen?
Yeah, we can.
Yeah. So the topic given to me is the achieving the best in the poor responder. Here our aim is good, achieving the best, but the situation is not good. It is a poor responder. We all know what poor responders are. I would always initiate my fertility talks with that procreation is a basic human right, and to give them all available treatment is our duty, because it is again the right of the patient. We have to make it accessible, available, and affordable. When we talk about poor responder, if you are sincere towards your job, probably you should know the burden of the problem. In today's time, the poor response incidence is 5 to 36% of all IVF cycle. Our OPDs are almost around 40% poor responders. Poor responders contribute to a huge financial and emotional burden on the couple. There is a heavy shift in the age of opting to start the family. I think that is the main reason of having such a heavy burden of poor responder. Advanced reproductive age is a new reality. So when it is a reality, we have to understand, optimize, and we have to finish them in fewer cycles. So when we talk about poor ovarian responders, is there any magic? There is no magic. All of us are clinician, yes, but we can make good strategies for the patient. So when we talk about making strategy or deciding the treatment, I think we must first understand what are the reason and behind and how our poor responders are going to behave. So all of us are doing IVF practice from more than 2 decades. Initially, there was no definition of poor responders. Then Bologna criteria came. And I think it was a Poseidon group who almost defined the poor responders, classified them. And to some extent, they have given us direction as a clinician that how to decide their treatment or strategize their treatment. And this acronym was built upon it is a Greek god of sea, which is son of fertility goddess. So that's nice. And he's father of many, many children. So probably that's how probably it will help our infertility patients as well. So how to define poor responder? Poseidon group has made it easy. There are 4 groups. So first 2 groups are unexpected poor responders. That means when ovarian reserve tests are normal, AFC is more than 5, AMH is more than 1.2 or equal to 1.2, but they unexpectedly behave like a poor responder. That means they produce less oocyte during IVF. So they could be young patients are group 1, older patients who are 35 and above are group 2. And the group 3 who have poor ovarian reserve, that means AFC is less and AMH is less, but the younger ones who are less than 35 is group 3, and the worst group is group 4 who are older and their AFC and AMH are also low. So broadly classifying, they are hyporesponders or expected poor responders, which could be young and which could be old. So it makes it very easy to define your patient and to decide your treatment protocol also. So when whole world is talking about poor response, so what is there in the numbers that we are so much talking about the egg numbers? And this reminds me a nursery rhyme which even today our children are studying, and we all have mugged up that hen. We all wish sometimes it lays eggs, sometimes 9, sometimes 10. I hope our patients also behave like that. So what is there in the numbers? So when we classify our IVF outcome, there are mainly 2 parameters which decide our IVF outcome. One is the female age and the number of oocyte, which predicts the live birth. Age we cannot change. Oocyte numbers is the game of entire IVF stimulation and deciding our strategies. So there was a first paper come from Sunkara et al. In 2011 where they say with the number of oocytes, our live birth will increase, but it stops after 15 oocytes. But they did not talk about the cumulative live birth, and the further and further studies added when they have calculated cumulative live birth. That means if we are not doing the fresh transfer or subsequent transfer, what is the total live birth? So with each subset of which each number of oocyte increase, there is an increase in the cumulative live birth, and this increase is even beyond 15 oocytes. So that means having more eggs is always good. So when we talk about number, is that our problem stops at number, or is there anything beyond quantity? Let's talk about quality. Why the oocyte is so important? Because oocyte represents the actual volume of embryo until blastocyst expansion. It is responsible for protein synthesis for embryo development from second cell division onwards, organelle formation, and the distribution that gives energy, structure, and proper metabolism of embryo until its implantation, membrane structure and transport mechanism, mitotic machinery, and 50% of nuclear DNA plus whole of the mitochondrial DNA come from oocyte. So oocyte is like a mother which will nurture the future embryo. And why age is so important? Because many of the poor responders, they belong to the group 4 category. That means they are advanced maternal age. So low reserve and age usually go in hand. So as with advancing maternal age, what happens is there's a reduced mitochondrial number and reduced ATP and metaphase oocyte, which if it was appropriate, there would be a normal meiotic spindle, and this process is energy driven, which is required for the equal chromosome segregation. But because it is a aged oocyte, there's a disrupted meiotic spindle, inefficient energy available to maintain the meiotic spindle. There is a chromosomal malalignment. There's a aneuploidy, poor embryo development, implantation failure, miscarriage, and genetic and birth defects are higher when there is a oocyte which is poor. So we have understood that aneuploidy is human. To her, he is human, and oocytes and embryo cannot escape it. There is a progressive age-dependent decrease in the probability of having a euploid blastocyst, and there is a strong association between number of oocytes and cumulative live birth. And again, the aneuploidy of embryo, it increases with the age. With this chart, you can see when the patient is less than 35-year-old, almost 40% of available embryos will be euploid. As the age increases, after 35, it becomes 50, at 40, it becomes 70, and above 42, it is 85. And we all know older is the oocyte, less likelihood of it turning into an embryo. So more oocyte, probably more embryo. And in this graph, you can see as the number of oocyte increases, the probability of euploid blastocyst will not reduce. Many people, they say that if you do a hyperstimulation or you stimulate more in comparison to mild stimulation, probably your percentage of having euploid embryos will reduce. So again, as the poor responders, there is a paradox of life that older women usually have lesser eggs. Her eggs are usually less competent to turn into a blastocyst and turn into a euploid blastocyst. But younger women with more eggs needs lesser eggs to get one euploid blastocyst, and older women will need more oocytes to get one euploid blastocyst. It means to say that probably even if your advanced maternal age or your ovarian reserves is poor, probably you need more cycles, more eggs, so that you can collect more embryos and you can have one or two euploid embryos. So this is the understanding from where we can design our strategies. Now, how to deal with this is very interesting paper. I think all of us, we live in big cities. At least those who are living in big cities can put an eye. This is a large multicentric trial in the China, and what they pointed out is poor ovarian response is associated with air pollution. But as a clinician, we can't do anything. So I think when we discuss clinically, we should avoid this and let's be practical. In a practical life, what goal we have to set is we can maximize oocyte yield per cycle. So there was a slogan in last ASHRAE, one and done. Probably in poor responders, it is not possible, but we can always strategize in a way that fewer cycles and we finish, fewer and finish. I think that should be our goal for the poor responders. More eggs, more embryos to achieve an euploid embryo. And this is very important for the patient is reduce time to achieve pregnancy, because there is a mental fatigue after that. Either the patient leaves you or they leave the treatment as a whole. So reduce time to achieve pregnancy is very, very important when you are dealing with a poor responders. So apart from counseling, definitely is very important. We have to make them understand where they stand for. But there's a long list of treatment, right from pre-treatment, adjuvants, OCPs, gonadotropin, trigger, lab work. So I have touched upon few important points here, which affects us day in and day out, and which questions us day in and day out. So first thing is about the adjuvants. So CoQ, DHEA, growth hormone, testosterone, melatonin, all these one by one I'll discuss. So this is a systemic review and meta-analysis again by Chinese group. So what they say is DHEA and CoQ are very useful. They have an obvious advantage in improving clinical pregnancy rate, and CoQ10 was best in improving live birth, especially in the group 3, Poseidon group 3. DHEA increases the embryo implantation. Growth hormone increases the number of oocytes available, and they have even compared the acupuncture and all those things. So it was of not of much use. Then this is a very good article by RBM online. It is seeking silver bullet. So are we finding our silver bullet in these nutritional supplements? More or less, this article has disregarded most of the nutritional supplement. They said you can use it, but there is no definitive clinical evidence. So what does CoQ10 does? It is an antioxidant. It is essential component of inner mitochondrial membrane and responsible for electron transport in mitochondrial respiratory chain for oxidative phosphorylation, leading to generation of ATP. With age, there is a reduction in intrafollicular CoQ10. Low CoQ10 is associated with higher aneuploidy in oocyte. CoQ10 supplementation is associated with good outcome in young poor responder. That means Poseidon group 3 patients. So then again comes the androgen. We all are being using androgen, either DHEA or testosterone gel. So what androgen does is androgen receptors are exposed by all stages of growing follicular. Follicular fluid androgen levels positively correlate with granulosa cell androgen receptor and FSH receptor. Androgen, they promote follicular growth, accumulation and responsiveness to the gonadotropin, and it improves the response to the stimulation in the ART processor. So when we give DHEA, so what it does is it increases FSH receptor, it rescues follicular atresia, reduces apoptosis, and promotes follicular growth. It increases IGF-1 and IGF-BP3 ratio, so increase oocyte quality and embryo quality. When we look towards the dictum, what Cochrane says is women who are identified as poor responders, pre-treatment with DHA or testosterone may be associated with improved live birth. Overall evidence is moderate. There is an sufficient evidence to show about concern about the safety, but more studies are required. So Cochrane has not given a full green tag to it, but there is a moderate improvement. These are the various studies. Half of the study says that it shows a great improvement. Another half says there was no clinical improvement by giving the DHEA. These are the another set of studies in the poor responders. Some will favor and some will not favor. Then again, a very important practice what we do is priming the estradiol hemihydrate in the luteal phase prior to ovarian stimulation. What happens is when we do a ovarian stimulation, there will be a pre-selected cohort. So to avoid that, these kind of priming will help us in getting a uniform cohort or maybe a few oocytes extra. In study group, the estradiol valerate was given in the luteal phase. The study group shows higher implantation capacity, greater frequency of clinical pregnancy, greater number of oocytes retrieved, and how it was given is you can see conventionally when lady gets period from day 2 we start the gonadotropin. Here in the luteal phase estradiol valerate 4 mg per day was given till the day 2 of the cycle, and then estradiol valerate was stopped and the gonadotropin was started as per the protocol. Then this is very important concept is the follicular output ratio or follicle oocyte index. So this is mainly for group 1 or group 2 where the adequate number of antral follicles are available, but they do not yield into the oocyte. If follicular oocyte index is less than 50%, that means it is less, and there should have been a reason, or in subsequent cycles, we should strategize in a way that our follicular output is better. So what could be the reason? Either we have given a low gonadotropin dose or adequate LH exposure was not there. There could be genetic and environmental factor. Genetic is mainly LH FSH receptor polymorphism. There could be an asynchronous follicular development. When we initiate the stimulation, beforehand only 1 or 2 follicles were selected, so they outgrow, others they do not grow. And technical issue like trigger could be wrong, patient has not taken trigger appropriately, or there was some technical problem during the oocyte pickup. So this is a study where they have proved that patient who has FSH receptor polymorphism, serine 680 carriers, have low follicular output ratio, and they need more FSH doses, and the frequency of these kind of polymorphism is higher in the hyporesponders. So probably whenever you find a low follicular output patient in subsequent cycle, we have to give the higher dose. And these are the Poseidon group 1 and 2, where they have summarized it that if we need an increased dose of recombinant FSH, we could consider adding LH. And if they are an elderly patient, then start with a higher dose of recombinant FSH, and probably LH is added as 150 from the beginning of the stimulation. Now come to the group 3 and 4. These are the difficult patients where really AFC is less and AMH is less, and especially group 4 who are older patients are much more difficult. So here we have discussed about DHA, testosterone, coenzyme Q, but then whether the high dose of gonadotropin will work, whether we should add, we should use only recombinant or HMG, or adding LH during later part of the stimulation, PRP, growth hormone, dual trigger, dual stimulation. So again, because it's a very wide topic, I'll touch upon a few important things which affects us day-to-day basis. So gonadotropin, I personally believe that any type of gonadotropin, what Cochrane says that recombinant HMG or FSH or urinary does not make any difference, but it is a comfort level of you, what you are comfortable and what is your clinical experience. Then doses. Study says more than 300 does not increase the outcome in the poor responders. But again, every unit has their own. We also sometimes use more than 300 for the poor responders. So whether the exogenous LH is required in poor responders or there is an endogenous LH which is present in our body, is it sufficient? So we all understand about the LH therapeutic window, that 2 less LH, which could be in the long agonist protocol, is suboptimal LH, will not allow the optimal follicular development, and extra LH can cause follicular atresia and premature luteinization of the follicle. So there is requirement of LH. So there are multiple studies which have studied about the adding LH during the IVF cycle. So this is that effect of recombinant LH supplementation on cumulative live birth compared with FSH alone in poor responders. So in that, what they have found out that LH addition has a significant impact on live birth, on moderate and severe poor responders. So those who are mild poor responders, they say it was not so helpful. So then one more studies which have studied the recombinant LH co-treatment in comparison to the FSH alone treatment. So what they have identified is in FSH alone treatment, they got a higher number of oocytes, but FSH LH co-treatment was associated with higher clinical pregnancy rates. So these groups of studies, they say addition of LH was of no use. And this was more of a marketing strategy to establish another product. Endogenous LH itself is sufficient even in the long agonist protocol. So one thing over and over with multiple studies have come forward is LH in the elderly women. When women is more than 35-year-old, probably LH induces FSH receptors, increases their responsiveness. It acts synergistically with IGF-1 and increase preantral and antral follicle. And when LH is added in elderly women, it increases oocyte quality and they better implantation rate in comparison to recombinant FSH alone. Then there is another protocol. What we use is when we begin with the stimulation, we had the letrozole. It is an aromatase inhibitor and it's supposed to increase the endogenous testosterone level. So mainly with the poor ovarian response or the women who are 40 years of age. So when letrozole was added in the IVF cycle, so there was a improved quality of embryo, higher clinical pregnancy rate and higher live birth rate. And the increasing serum testosterone level may reflect follicular growth during the ovarian stimulation. Then another common thing what we always confuse about the growth hormone, whether it is useful or not, or it is just a costly add-on, or it is really useful. So again, growth hormone receptors are expressed in ovarian granulosa cell, theca cell, oocytes. It raises the sensitivity towards the FSH, regulates ovarian function, promote follicular maturation, and improve follicular development. It can be given, various studies have recommended various doses from 4 IU to 12 IU per day till HCG trigger. So what Cochrane says is growth hormone use as an adjuvant in IVF protocol has uncertain effect on the live birth and mean oocyte number in normal responder. It slightly increases the number of oocytes and pregnancy rate in the poor responder, but it is uncertain effect on the live birth in this group. So more and more studies are required. And this is a meta-analysis of RCTs done by a large Chinese group. what they have concluded is they have included 15 RCTs, which involve almost 1,500 patients. And they have analyzed and concluded that it increases the live births, it increases clinical pregnancy rate and number of oocyte retrieve. So it is a good adjuvant in the poor responders group. Then if after stimulation about the trigger, so we have either GnRH agonist as a trigger, we have HCG as a trigger. But when we talk about poor responder, is there something we can do about the trigger? So a lot has been spoken about the dual trigger. That means instead of only HCG, you give HCG as well as GnRH and agonist as a trigger. So it is a large, it's a randomized controlled study where 160 women were studied, 80 were in each group. Dual trigger was associated with higher number of retrieved oocyte, metaphase oocyte, total number of grade 1 embryo, usable embryo and transferred embryo, lower cancellation rate, and significantly higher clinical pregnancy rate. So definitely dual trigger is associated with a better IVF outcome in poor responders compared with a single group. Again, another more studies which says that dual trigger is useful in the group 3 and group 4 Poseidon poor responders group, and it causes the better statistical outcome. Then this is a retrospective cohort studies where they have divided again in HCG trigger and the dual trigger. And if you see the p-value here, the number of oocyte retrieved are higher. And you can say pre-ovulatory follicle were almost similar in both group. But the number of oocyte retrieved and number of metaphase oocyte in almost in a similar number of pre-ovulatory follicle is higher. And the higher number of usable embryos and higher number of the top quality embryo is p-value is significant. So then comes the dual stimulation. So one thing for sure in poor responders, you might need more than one cycle. So you have to plan it like that, something like embryo pooling. Either you do repeated IVF stimulation, one cycle, pool embryos, and probably then you can plan transfer. Otherwise, if you want to cut short your timing, probably dual stimulation is upcoming concept. So dual stimulation is a newer strategy, and what it does is it reduces the time between two pickups. First and second pickup difference was 15.8 days in dual stimulation, whereas in the conventional stimulation it was 144.1 day. So that is very, very important because the psychological burden of the patient, once you do one cycle, whether they do not get embryo, it is very difficult to bring them back. So the dual stimulation, what it does is the first stimulation is similar. You start a stimulation on day 2, day 3, give a GnRH agonist trigger. Here, don't give HCG trigger, do an OPU, give a gap of 3 to 5 days, and then start the second stimulation. And second stimulation is similar. And lot of studies are coming up which says that luteal phase oocytes were equally good, and they got good quality embryos and euploid embryos out of the luteal phase embryos. So here, if you compare that two group of patient, dual stimulation 100 patient and conventional 197, the patient performing two ovarian stimulation was 100% in dual stimulation, whereas in conventional only 9% of patient come back for the second pickup. Day between the two pickup was 15 days in dual stimulation. Here 1 days, that is more than 3 months. Patient at least got one euploid blastocyst was 31% in the dual stimulation, where only 20% in the conventional stimulation. And in follicular phase, they got 14 patient got blastocyst. In luteal phase, 90% got blastocyst, where in conventional stimulation, because second stimulation, very few people did, only 2 patients got. So patient with at least one live birth was 15%, and here it is 8%. So probably if we have to make sure that patient does more cycle and we have to reduce the time to achieve pregnancy, probably dual stimulation is the way forward. We have to increase our understanding. today's time I'm doing only for the international patient. I don't do for the general patient. Then when we talk about what is assumed and what we do day in and day out, we should not forget about innovation and intervention. Human mind is not a static mind. We have to always look forward. So few things are intra-ovarian PRP or stem cells, follicular cortical stimulation, mitochondrial transfer. PRP, I think all of us are well versed. Then in the lab, because these low ovarian reserve patients are most of the time are elderly patients. So PGTA can help them to select a one euploid blastocyst. Again, this is the same kind of slide where when we get higher number of oocytes or when you increase the gonadotropin dose, probably euploid probability will not change with the higher dose of the gonadotropin or getting more number of the oocytes. So if we have to talk about the poor responders, I think we have to assess the patient well, AFC, AMH, other pharmacogenomics, what is the patient outcome, follicular output ratio. We shall not forget age because it is one of the most important outcome. Put some parameters for the male factor also. Then we have to devise our stimulation strategy, and we can add on something in the lab about PGTA, and some people, they prefer to do ICSI for all poor responders. So what Poseidon has taught us is you combine all the quantitative and qualitative parameters, personalize our treatment. It could be multiple cycle embryo pooling to one cycle to dual trigger or dual stimulation. Try your level best to get one euploid embryo transfer. It will reduce your time to achieve pregnancy. In the end, it is a patience, perseverance, and personalized treatment. And poor responders, we shall not forget, they are the new reality of our OPD. In my OPD only now, my maximum patient are 38 to 43 years of the age. So again, it looks like a joke, but I will use it. Being poor is a state of mind, and perfect strategies can win over the situation. We can come out of it, and a winner is just a loser who has tried one more time. And thank you very much for the patient hearing.
Thank you, ma'am, for a lovely talk and very, very clear. I am not an IVF specialist, but still I am so engrossed in your talk and very nice points. I'm sure why Madhu has selected you, and now I can understand. You are very clear in your concepts, and there is no ifs and buts. It is dual trigger, dual stimulation, CoQ, DHEA, whatever is the need, you told very clearly. And about the mitochondria also, now I am thinking in the oocyte, the mitochondria is the most important factor. So much of nice points, madam. I wish we can have you for another session also in the future with a different topic. Thank you so much. Thank you, Madhu. I asked the chairpersons to just say your expert comments, ma'am.
Thank you,
Thank you, ma'am. It was an excellent presentation. Even I am also not an IVF specialist, and I learned so much from you. And you explained it in such a simplified way. I really enjoyed your talk, ma'am. I just wanted to ask one thing, like from in small cities, if there are poor responders, when should we refer those cases to your higher IVF center? What adjuvants should we add so that they can have better IVF outcome?
See, in a practical life, I'm telling you, adjuvants are good. But what literature says, wait for 3 months and then start the stimulation, probably that is not practical. You can put on adjuvants, and either you do yourself. So adding LH and all, if the cost is a problem, then HMG is an answer. And what personally I believe is you have to counsel that they might need more than one cycle. They might need more than one cycle until they don't decide upon doing a treatment. Adjuvants are always there, lifestyle improvement, all those things will really help. So what personally I believe on CoQ in any form, if they're obese, lifestyle changes. DHEA is a harmless drug. I have not seen much improvement, but giving is no harm. So these things we definitely do that. And in fact, what I have seen is sometimes these poor responder, I do an IVF and very next cycle they conceive naturally also. There's no scientific explanation for it, but I always say them because you have put one foot forward, God has helped you, but it is very common. So poor responders are in the end very tricky patient. There is so either you treat yourself, you want to send us till the buying time, you can put them on these kind of adjuvants.
Thank you, ma'am.
Good evening. Good evening, madam. Madam, I want to know how to use Stabet gel in poor responders.
I don't use gel regularly. I use tablets, but you can
Okay.
use gel also in a similar way. So I give whatever brand you use. I use usually hemihydrate. So 2
Yes.
mg BD till they get period from the luteal phase.
Okay, in
Phase.
previous cycle, once.
Previous cycle. So suppose
Okay.
if you are using antagonist protocol now, so if you
Yeah.
have not used, what happens is there's a pre-selection of the follicles. When there is a
Okay.
luteal phase is going down and in the luteal follicular transition phase, the dominant follicles are being selected, especially in the poor responders, because their
Okay.
cycles are short and everything is happens very, very early. So especially in poor responders, these kind of manipulations will help. So
Okay.
gel also you can use, but the cost is more of
Yeah,
gel.
of course.
There is some controversy on PRP and stem cell, madam. You have any?
It is not a proven technique, ma'am. It is not a proven technique. And what happened is I have not used it for a very long time. But in a practical life, I'm telling you, what happens is because PRP is everywhere and there is so much of buzz around. So because I started losing patients, that's when I started using it. There is a slight benefit. Probably these are the borderline patients who are get benefited. In fact, there are few studies which says one pickup induces same kind of, because some needle prick, some changes happen. One pickup also induces some kind of changes in the ovary, that your usually second pickup your outcomes are much better. So PRP is fully controversial, but we cannot deny that everybody is doing it, and to some extent we have to do, because this is the reality that your patients, even 43, 44, 45-year old are also are your patients who are not willing for because if we don't do PRP, what next is the donor oocyte. So even if there is a slight success rate, patients are ready to take it. But there's a word of caution that anybody can do PRP. It is very simple, but then your processing technique should be good. And more than that, that aseptic precautions are very important, because you are pricking in the ovary. There are two ways, either transvaginal scan and so that is the most common. Laparoscopy is so transvaginal scan with the OPO needle you do. So you have to learn the right technique and proper aseptic precaution. Otherwise, unnecessary, we are going to do more harm.
Madam, one more question. I have never used dual stimulation. It's very first time I come into knowledge of dual stimulation.
See,
In the
what
same.
happens is, let's begin this talk like that. When we started stimulation long back, when I learned IVF, we
Yeah.
used to down regulate. Then we came on antagonist protocol. Initial
Antagonist.
part of antagonist protocol, they say you check E2 and progesterone. Day 2, if E2 is high, progesterone is high, don't stimulate. Then we came on PPOS protocol, where we are exposing patient to the progesterone and we are saying the oocytes are same. And then we came on the random stimulation, that you start anytime and the outcome is same. So this dual stimulation protocol basically came for the cancer patient or very
Okay.
elderly patient, like because we are in Bangalore, all big city people will get international patients. So sometimes international patients have a very less window of time. So these are the areas where you could do. Otherwise, what happens is, whenever you break a traditional thinking, you have to justify. Suppose second phase of cycle you don't get good oocyte, so your patient also should be equally understanding. Otherwise, you can always do a single stimulation, do a Lupri trigger and a GnRH agonist trigger. In 10 days, less than 10 days, they get a period, and you can do a conventional stimulation also.
Okay.
So there is nothing so great. It is basically, it saves the time. And when you practice more and more, what you realize is there is a fatigue in the patient. If
Yeah.
you linger on for a longer time, then probably they leave the treatment. So dual stimulation is basically for certain subgroup of patient, not for all.
Okay. Thank you, ma'am. Thank you for nice talk.
Thank you so much. Very, very nice topic and interesting session. I really enjoyed the session. Madhu, I just call
Yeah,
you.
ma'am.
Thanks, yeah. And I
Yeah, ma'am.
the chairpersons just wrote for me that last request. Komal, Madhu, Manu, Nisha, Panit, everyone, whoever is logged in. Thank you so much. Madhu, please say the
Wishing you all the luck, ma'am. Wishing you all the best as well, ma'am. And thank you all chairpersons, and thanks to the two great speakers who have actually helped us to understand the topics in depth. And thank you so much, Vijaya ma'am, for conducting the webinars, which would obviously enlighten the practitioners and also the learners. Like even when they are in the fellowships, even if they are the postgraduates, they understand in depth about all these knowledges. And thanks for one and all for giving your time, for staying back with us. Thank you so much. We would love to create much more academics like this in future too. Thank you, ma'am.
Thank you all. Thank you,
Thank you, ma'am. Thank you, chairpersons. Thank you, Madhu.
Thank you,
Good night.
Jay.
Komal, good night. Manu,
Good
Panit.
night, ma'am.
Yeah, thank you. Omana, thank you.